might be good reasons for not hiring. Unlike some of the more case fatality ones, referral institution. You certainly expect that to land the things that they're doing.
You're right on time. I guess.
Hello,
How
hi.
are you?
Very good, I'm Jim.
Jim. I'm
Ricken.
Anna.
Hi, Anna.
Hi, Steve. How are you? Good to see you.
Hi, how are you, Mark?
Great to see you.
Good to see you too.
Sorry. Are you set? Do you need anything?
Just give me 1 minute.
No.
Get
Actually,
myself organized.
You have like a good 5.
Oh, okay, perfect. I'm fine.
People filter in.
Okay, perfect. Perfect.
But let me know if you need anything.
You have the slides ready and
Yeah, and
everything.
make sure to switch them out in between.
Okay, and should people come to the podium?
Yes.
Okay.
Not during the discussion.
No. But for their presentations. And how long? The presentation? 15. Okay. Okay.
And we can stand at the podium and do our own slides, right? Yeah. We don't have to, okay.
Yeah. There's a clicker and or from the laptop.
Yeah, yeah.
You were right, there was a lot of delivery.
Because although I have to pay, I think Dan's set, but do you
Maternal Health Initiative. I think I mentioned it when I first started, but it's been a long time. Nice to have you
I was
here.
here for another event. I don't remember exactly when.
Yeah.
But several months ago.
10th, I think. Yeah.
February 10th?
It's fast. It went by really fast. Let me show.
Whether so they've got fancy ways of tracking.
Is that what she was talking about in the morning?
Yeah, I can't
Hi, do you both have to train up?
that was in 2 different sessions, so I get confused about which one she's talking about. Yes.
Thank you so much for joining us.
Good.
So I plan to, like, unless somebody else says it first, I'll just say that I'm gonna
An interesting event.
Yeah,
in Charlotte. My college.
this is an area, like when I was with MCHIP, I was
Right.
doing quite a bit of work in this area. Not quite so much now, because we've got like our M&E team is,
So I'm starting from,
I mean,
to
they're
make
kind
sure.
of taking the lead on indicators. I don't want to crowd them, but it's something that I'm very interested in.
So you leave that one up, and then
Lara's very good.
you say this, and then
Wait, hold on. No, actually, you start here.
okay. So you're
I'll
talking.
leave this one up, and then you can go.
Thank you very much.
Okay.
push it to the next one. How's that? Okay. Those lights are really bright.
Quite bright, aren't they?
Being on television or something. Yes, we are technically speaking. I want to make sure they can see all of your gray hairs and wrinkles. Yeah. Bow patch. Who else is on that? MDG thing besides
You tell me when.
It's about 7 after, and I was
Joylyn?
You tell me when. I'm ready.
no, 4.
Gwyneth. Oh, she might. Was she there? She might be.
All right, so let's go ahead and get started. Let's begin today's event entitled, My name is Graham Associate for the Maternal Health Initiative here at the Woodrow Wilson Center. Today's event is brought to you as part of our Advancing Dialogue on Maternal Health series, where we work to identify challenges and discuss strategies for advancing maternal health. This series is generously supported by the Maternal Health Task Force as well as UNFPA. As many of you know, the Wilson Center is a formal memorial to our 28th president, and we aim to bring the worlds of policy, practice, and academia together. We were voted the top think tank to watch in the U.S. and one of the world's top 10 think tanks recently. Speaking of watching, I wanted to mention that today's event is being webcasted live. So what that means for folks here in the room, that when we come to the discussion, I'd ask that you use a mic so those tuning in can hear you. And my colleagues will be around with mics. And please introduce yourself and affiliation. I also wanted to mention that the Twitter handle that we're using today is MHDialogue. And the Wi-Fi password, for those who needs it, is against the wall. It does change every other month, so if you're having any problems, you might need to reload the username. Before I direct your attention to our esteemed moderator, I wanted to point out why we thought having such an event the Monday after Thanksgiving was as important as it is. And that is because women's rights and empowerment, including access to comprehensive reproductive health and maternal health services, is really important to our work, and our work to help transform lives and societies, and such rights are fundamental to human development. And so now, as I turn to our moderator, Dr. Anna Langer, Professor of Practice of Public Health, at Harvard University, and Director of the Women's and Health Initiative and Maternal Health Task Force. Very esteemed. It was quite a mouthful for me to get all that out. As I turned to her, I wanted to say that I'm looking forward to learning more about the key indicators suggested to assess maternal health after the MDGs expire, and as we think through the post-2015 development agenda, including the Sustainable Development Goals. So thank you, Anna.
Thank you, Sandeep. Thank you, everyone, for being here. Thank you to the panelists for joining us. Thank you to the Woodrow Wilson International Center and to UNFPA for co-sponsoring with the Maternal Health Task Force this series of events. We are generously funded by the Bill and Melinda Gates Foundation. As you all know here, I'm among experts. We've made big progress in terms of the reduction of maternal mortality, in particular, over the last 15 years. Today is the first day of the month that keeps us still away from 2015, the mythical year when the MDGs will expire or will come to an end, at least this iteration. So I think that's another reason why thinking about measurement and other maternal health issues this day, right after Thanksgiving, it has some kind of symbolic meaning. I mean, we need to get ready for the next iteration of Sustainable Development Goals and find a way to keep the momentum that we've managed to reach over the last 15 years. One of the reasons why the MDGs were relatively effective in reducing globally maternal mortality MMR by 50%, although we know that there are many countries that are still lagging very far behind, is because we were able to measure better the maternal mortality levels and other indicators that were quite critical as a mechanism to track progress towards the MDGs. But of course, there are still many challenges, and we will talk about some of them today. Measurement is obviously very complex, and it involves many aspects of maternal health. We will talk about the measurement of maternal mortality in general and what we are doing. The Maternal Health Task Force, along with other partners, USAID, UNFPA, WHO, and other partners, as part of the Ending Preventable Maternal Mortality work that is focused on establishing meaningful goals for the next 15 years in terms of reduction of maternal mortality. So I think we will touch upon that. We will talk also about how to measure the quality of maternal health care from a user's perspective, and what women are able to describe as the content of the care they received in the facilities. And we will also talk about, other aspects of measurement without covering everything. But I think that what we will definitely do is touch upon some of the most critical aspects and hopefully discuss with all of you what would be the most meaningful ways to overcome the challenges that we still face as a community, and come up with innovative and meaningful ways to measure progress in terms of maternal health. We will have presentations from each of the panelists here, and I will introduce them in a minute. And we have one discussant that will summarize the main messages, and I'm sure adding a few more critical messages. And then we will open it to questions and discussion with all of you. Again, as you are as you are experts in this area as well, of course, it would be very, very important to get your perspective on what the most important measurement challenges are and how to overcome them. So, I think I will introduce each speaker before his or her presentation instead of doing it all at once. So it's not so, the introductions are not so long. So I will start with Steve Hodges. Steve is a MD, doctor in public health. He's the senior technical advisor for newborn health, providing technical leadership and support for Save the Children Saving Newborn Lives program. He's a public health physician who trained at McGill and UNC Chapel Hill. He has broad public health and health services interests, but his focus has been in public health practice. Through most of his career, Steve has focused on community health workers, and beginning when he was a volunteer in North India almost 30 years ago. He has published extensively on community health worker innovations in Nepal and other aspects of measurement and quality of care. Steve?
Okay. Could you pass me the... yeah, that's it. Okay, thanks. So this afternoon we're going to be I guess covering a range of issues around measurement and maternal health programming. I'm going to be coming at this mostly looking at the needs of people who are working in the system, so healthcare service providers and managers. Some of what I'm going to have to say is going to be familiar to some of you, because some of these are kind of perennial bees in my bonnet. So as managers, if we don't have a reasonably good idea of how our programs or services are actually doing, we're unlikely to be able to improve their performance. So taking measurement seriously as program managers means driving with our eyes open. Measurement using surveys like MICS or DHS or health facility assessments, which in most instances are done on a one-off basis, can be very important at global level for performance tracking and accountability, and also as a basis for program planning. But as far as the ongoing day-to-day work of ensuring that programs and services are working, there's another, there are other kinds of data that are needed, and we need closer to real-time data. So at the end of the day, we do need to be relying on routine health information systems. And we have a tendency to give short shrift to this particular measurement piece. When we do give it attention, the focus is usually on generating new indicators to add to already overloaded HMIS systems, which also adds to the documentation burden of health workers. Instead, I think it's quite important that we look at how to make health management information systems more functional. And if we're trying to get as good a handle as possible on actual program performance, it's best if we can get as close as possible in our measurement to impact. Some of you are familiar with the quality of intrapartum care indicator, which includes both intrapartum deaths as well as very early newborn deaths. And this is an uncommon case of an indicator that can feasibly be collected through routine documentation, which is getting pretty close to impact. Usually, however, we need to be content with tracking coverage of some particular intervention. That is to say, the proportion of the population that need an intervention that actually get it. In the child health world, if we use the word coverage, this isn't really problematic. It's used to refer to specific interventions of known efficacy, things like measles immunization or use of oral rehydration salts for diarrhea or antibiotics for pneumonia. But the word coverage gets used in a lot of other ways, and to avoid that confusion in saving newborn lives, we pretty consistently use the term effective coverage, and so effective coverage gets at what's actually being delivered. So that would mean the proportion of the population that need an intervention that actually get it delivered in a way where it can be expected to be effective. So whether we use the word effective coverage or coverage, I think it's important to be using it in that sense, where it's coverage of what, so what's actually being delivered. So for routine monitoring, as our basic measure of program performance, we want to be able to approximate as best as we can this coverage or effective coverage. And when we see less than desired performance, so that's this side over here, then we need to dig in and get more information about why it is that things aren't performing. And this is another term that we use in Saving Newborn Lives, implementation strength. And I appreciate this is not necessarily a self-explanatory term, but it basically means that all of the conditions are met to be able to deliver the service. So by analogy, if our car won't start, well, then we have to start into some problem solving and look in a little more detail. So is the battery dead? Is there fuel in the tank? So similarly in our program, if effective coverage is low, then we have to start asking questions like, are there key program commodities needed for this intervention that are not consistently available? Or are there health workers needed for delivery of the intervention that are not consistently at their post? This issue about how the term coverage is used, I think this is a besetting problem for us in maternal newborn. I think there's a recognition that the way coverage is often used, which usually refers to just contact, that's not sufficient. So we talk about coverage versus quality. But I guess as it sounds, as I hear these words, because coverage in child health has this fairly unambiguous meaning associated with delivery of specific interventions, we tend to use the word coverage and the quote-unquote coverage indicators in maternal newborn as if they were a good measure of overall program performance, and that gets us into trouble. Similarly, quality for me personally doesn't appeal to me very much as a term for this because I find that it's too vague. Like there's any number of different things that can be subsumed under that term. So for me, I find it's more helpful to frame this as contact versus content rather than coverage versus quality. In this case, the contact is the opportunity for actually delivering a service or an intervention. So contact is certainly important, but I think at the same time we need to be able to differentiate between contact as a necessary condition for delivering an intervention and then contact as an overall measure of performance. And the problem arises when we use contact measures as a proxy for overall program performance. This term benchmark indicator, as far as I know, was first coined in maternal newborn by Wendy Graham at University of Aberdeen. And key examples are these indicators associated with MDG 5. And these kinds of indicators are very important, I think particularly in generating political attention and money for programs. But at the same time, there can be pitfalls in the way these benchmark indicators are used. They're powerful, like they direct attention, and there's at the country level, in kind of complying with the use of indicators like this, there are a number of instances where there are indicators which are variations on these survey benchmark indicators that are included in health management information systems. So the two key ones here, the skilled birth attendance indicator, and then the 4A and C visit indicator. These are used in a lot of, or versions of those indicators are used in a lot of HMIS systems. And when you've got a good indicator that's used in this way, an indicator that's used as a global benchmark indicator that gets picked up in an HMIS system, that's not necessarily a problem. It can be a good thing. So I would say immunization indicators fall into that category. They're directing attention appropriately. But if we use the wrong benchmark indicators, that can be a problem in the sense that they can misdirect attention or distort program effort. And I would make the case that use of contact indicators as some overall proxy for program performance has that effect. And I would put the SBA and the ANC 4+ indicator, I would put them forward as prime examples. So I would like to make the case that as we move forward after 2015 and the MDGs, that we drop use of the SBA indicator in the way it has been used up until now as an overall global benchmark indicator that stands as a proxy for program performance. One issue with the SBA indicator is that it purports to measure performance of a strategy. So the strategy is the skilled birth attendance strategy. And so you measure the strategy with the skilled birth attendance indicator. And presumably the strategy is one of ensuring that all deliveries are attended by health workers who have suitable skills, right? And then the assumption is that if these deliveries are attended by health workers with suitable skills, then that's going to result in better outcomes. But the indicator doesn't measure what it says it's measuring. At best, what it measures is the proportion of deliveries that are attended by someone who the woman who's giving birth believes belongs to a particular professional category. And that would be a physician, nurse, or a midwife. So that's all it measures. It doesn't measure skills. But there are more important reasons for dropping the use of SBA as our principal benchmark indicator for maternal health program performance. And I would say that the key issue with it is that it distracts attention from where it's needed. Now, what I'm going to show you is some analysis of DHS data. This is from a set of countries for which we've got 2 DHS data points at different points in time for neonatal mortality. And so we look on this axis here at the change between those 2 points in time in the skilled birth attendance rate, and then the change over time in the neonatal mortality rate. Now, what we would expect is that the more rapid the increase in SBA, the more rapid the decline in neonatal mortality, right? So if this really made a difference, if pushing up your SBA rate fast if that was really an effective strategy for reducing neonatal mortality. Okay, this is what we actually see. So what we actually see is a moderate negative correlation, where the more rapid the increase in SBA, the slower the decline in neonatal mortality rate. So it appears that too exclusive a focus on pushing up contact tends to result in neglect of content. So as we see, the use of skilled birth attendants as the main measure of maternal health program performance is misleading, and it tends to encourage misdirected program effort where the focus is on optimizing contact rather than focusing on what happens during that contact. The contact does matter as an important process dimension, but not as an overall measure of program performance. So I would suggest that rather than tracking skilled birth attendants, that we track institutional delivery rate, which typically, these rates are very similar, but the institutional delivery rate is what it says it is. It doesn't pretend to be an indicator of overall program performance. It unambiguously is an indicator of contact. So as with the skilled birth attendants indicator, the ANC4+ indicator also tends to misdirect program effort, focusing attention on the contact rather than on content. And I would suggest that it's also inappropriate to be using this kind of a contact measure as a proxy for adequacy of antenatal care. High ANC4+ quote-unquote coverage is perfectly compatible with empty, ineffective antenatal. And I don't have time to get into presenting data on this, but we have a paper here in Global Health Science and Practice if you want to look at that further. I'd like to end with a few comments on use of routine data for improving program performance. Often, this kind of data is spoken of dismissively as of being of such poor quality and validity that there's no point in paying attention to it. And I think it does have to be acknowledged that in many instances, the data that we have from these sources is far from ideal. It's usually not population-based. In settings where the private sector is a major provider of care, most often from the private sector, they're not submitting reports into a national HMIS, so you can be missing a lot of what's going on. It's certainly true that the quality of data in routine health information systems and the completeness of the data are often poor. It's often the case that the things that we're really interested in are not readily measurable through routine health information systems, and what is measurable isn't necessarily all that useful. Perhaps more fundamentally, there's the problem that even if you've got data that are potentially useful, HMIS is treated as an administrative function. So, it's a documentation burden, and you send it up into the administrative ether and nothing ever happens. That doesn't have to be the case, however. Specifically for maternal newborn, one of the challenges that we face is there are a variety of aspects of performance that we need to be measuring, and for routine preventive services, for example, for some elements of antenatal, like whether or not a woman gets her preventive, anti-malarial, or whether she gets oxytocin given immediately after delivery. In principle, that's something that can be relatively easily kind of captured in a register and reported. But a lot of what we're interested in maternal newborn is management of complications, and that's an inherently more difficult area to track through routine systems. We do have cesarean deliveries typically tracked through health information systems, but we have the same issues with cesarean delivery rates from HMIS as we do with surveys, that even if we've got a rate that looks reasonable, those that need the service aren't necessarily getting it, and those that get it don't necessarily need it. There's I mean, another area that we're certainly very interested in maternal newborn is things that often do happen in the course of provision of care that shouldn't be happening. Not non-medically indicated cesareans being one of them, but also in many settings there's very suboptimal infection prevention practices and conditions, and somehow if we want better performance on that, we need to be monitoring. There are a range of other important issues of quality having to do with iatrogenesis that we need to have a handle on, and if we don't measure them, then we're less likely to make progress. So at the end of the day, with routine health information systems, we do have to make the best of what we've got, and that's often imperfect data. But by triangulating from multiple sources, we can get a better sense of what's really going on. So depending on what the service is, sometimes we can be looking at this in terms of stockouts of commodities, the kind of service delivery data, supervision data. And there are examples out there of creative ways of doing documentation in a simple way that give more data. In Latin America, there's a standardized perinatal record that's got a lot of rich data. In Nepal, for this community-based management of pneumonia, they have a single page treatment record that is readily auditable for looking at aspects of quality of care. I mean, another I think good example of doing more with routinely collected data is work that URC has done in Ecuador, looking at data that are used at the health facility level for quality improvement processes that are then kind of captured up, kind of further up the system, so that you've got active decision making and problem solving, making use of facility data, all the way kind of up the chain, but beginning at the health facility level. So there's much that can be done, and but for that to happen, we need to be giving attention to this area. And I would really make the plea that if we want better services and better outcomes, that in the first place we need to start paying attention to measurement is at the level of the health facility.
Thank you. Thank you very much, Stephen. Thank you for challenging some of the most common measurement paradigms and also for discussing some innovative approaches. Now we will hear from Jim Rica. He has over 20 years of experience implementing and studying facility and community-based health programs in maternal, newborn, and child health, reproductive health, HIV and AIDS, and infectious diseases. He has experience in implementation and operations research, monitoring and evaluation, project management, training, capacity building, and strategic planning. Jim has produced a wealth of materials and published on the development of new maternal and newborn health indicators, sustainability of health programming, institutional capacity assessments, health facility assessments, and analysis of the effectiveness of NGO-facilitated community-based programming. Jim worked on the previous Maternal and Child Health Integrated Program, MCHIP, and also for the American Red Cross in Latin America, and as a faculty member in the Georgetown Medical School Department of Family Medicine. Thank you, Jim.
It's okay if I?
Yes, please.
I'll stand up. Is this microphone's on? Okay, great. Great, well, thanks for inviting me, and I'll try not to repeat too much of what Steve said. We used to work together, so he influenced a lot of my thinking, and I even stole a slide or two from him. Might be obvious which ones those are. Well, as Steve ended, I'll begin and say that one thing I think that's definitely a truism is that we measure what we value, and we value what we measure. So I think this is really an important thing to make sure that we're measuring the right things. There's a funny story about someone who is under a spot, under a light, and a guy comes up to him and says, "What's going on?" He said, "Well, I'm looking for my keys here." And he said, "Well, let me help you. Look under this street light here at night." And they look for a few minutes, and he said, "Are you really sure you lost your keys here?" And the fellow says to him, "Well, no, I don't think so, but the light's here, so I figure I should look here." And I think, unfortunately, that's the case. Because we're able to measure certain things easily, we do that. But as Steve pointed out, I think that the fact that it's easy to measure doesn't necessarily mean it's the right thing to measure. So I just want to talk about a couple of experiences, some things that we have done under MCHIP and now under and are planning under MCSP in terms of measurement, and then maybe throw out a couple of recommendations. And this is by no stretch, comprehensive, but just a little bit of a flavor of some things. So again, as Steve said before, skilled birth attendants and antenatal care attendants are kind of where we're at in terms of trying to measure, quote, service statistics. Of course, people measure maternal mortality rate and other things of the sort, but in terms of supposedly service statistics, this is what we measure, and as Steve has said, this is really contact and not content of care. And people do then, I've been in multiple discussions where people say, well, we need to measure the quality of care, which certainly we do, but if we're going to be kind of tracking things globally, a lot of times that discussion gets bogged down into, very detailed sorts of quality improvement methodologies that probably don't belong in a discussion of what we track on an ongoing basis. So I just want to contrast, again, as Steve said before, child health indicators, the benchmark indicators are things like DPT rates for immunization or measles immunization or pneumonias treated with antibiotics or diarrheas treated with ORS. So very specific diseases, interventions. We know, to some extent what's going on. Of course, we know there are also some problems with some of those indicators, but on the other hand, there's sort of known unknowns, so to speak. I think we're in an unknown situation to some extent in maternal health. And if child health were measuring the same things as we measure in maternal health, they would be measuring simply things like outpatient visits or number of hospitalizations. And I think that clearly they would have considered that inadequate. And I think we're in an inadequate situation right now in maternal health. The reason we are is there are things that are difficult to measure, but hopefully there are some things on the horizon that are encouraging. Just want to bring up two things that really affected my thinking. One article by Steve Harvey and colleagues several years ago where they talked about, are skilled birth attendants really skilled? An article in the WHO Bulletin, and measured the actual services, not really actual services. These were simulations. And so they did some simulations with skilled birth attendants, and they found generally, even for a minimum skill set, that there was only about a 50% adherence to minimum quality standards for things not only like emergency obstetric and neonatal care, but also even for routine skills like active management at third stage of labor or essential newborn care. Another article that just came out last year, I think really kind of put it in the same vein. It was by Susan and colleagues from WHO, a multi-country study. I'm sure a lot of people here are familiar with this study, showing that essentially the bottom line was this: high coverage of essential interventions did not imply reduced maternal mortality in a very large data set, studies prospectively. They looked at whether or not skilled attendants were delivering the things that we know matter, things like supposedly proper management of postpartum hemorrhage and things like magnesium sulfate use for preeclampsias and eclampsias. But these were ticked in registers and then looked at later on. They didn't look at any deeper into how well delivered these interventions were. So it does show some of the trickiness maybe I don't think this is in contrast maybe to what Steve said, but I think it does give a little bit of subtlety to the idea that we can track things in registers. I think we need to be careful about what exactly we're tracking in registers and what the meaning of that would be. I won't go over the maternal mortality rate and skilled birth attendants. I think, again, this scatter plot is very similar to the one Steve showed. If we look at the R-squared value on this, in other words, the amount of variation that's explained in 30 high priority countries by the skilled birth attendance rate that it explains very little of the variation. It was only 16% of the variation was explained. And in fact, if outliers are taken out, the two biggest outliers there are China and Afghanistan, it's even less. It's less than 10%. I think we should be careful that we don't have confirmation bias, so to speak, just because we think that this matters, that we're kind of trying to find data that kind of only supports our assumptions. Because if we drew a plot like this for road network or even per capita expenditure on pet food, we would also find a correlation with maternal mortality rate. So, not to put too fine a point on it. So where could the data come from, and maybe get there first, and just I'll end with what sort of things maybe we ought to be measuring now. Of course, as Steve said before, health information systems is one very important place. Data use is important, and people should be collecting the data that they're going to use. That's an important point, but maybe I'll expand the discussion a little bit. There are certainly secondary data sources out there, national household surveys, national facility surveys. I just want to go over real quickly some information we got that maybe has a little bit of bearing on our thinking about what it would be like to collect data from those sources. So there was a study that I worked on with Cindy Stanton, and many other people did too, under MCHIP, where we looked at self-report from women who had recently delivered about the sort of services that they had received during labor and delivery. And this would be the sort of data we want to know. We want to know that it's valid, the sort of things that women would report if we were going to try to collect things from a household survey. So we kind of put that to the test. And the study design was very similar to one you'll hear about from Charlotte Warren later on in some other places. First, there was an observation of care study that was done, and we actually had skilled observers, not skilled birth attendants, but skilled birth attendant observers, to look and see what sort of services were delivered. We waited 8 to 10 months. We went back and found those women again, which wasn't an easy task, but we mainly did that. And then we asked them what sort of care did they actually receive, and we compared the two. We were disappointed in the results, to say the least. So here is quickly a very brief summary of what we found. We tried two different ways of validating the data. One that was on an individual level, which is I won't get into the statistics, but it's area under the curve. It is a combination of the sensitivity and specificity of the measure that more or less tells you the accuracy in an AUC of 1 and area under the curve. In other words, what I'm calling individual accuracy. 1 would be 100% of the time. What the woman said was what actually happened. An AUC of 0.5, about 50% of the time it's right, would be like flipping a coin. And if she says yes, it's just as likely to be no as yes. We've set a standard of fairly low, but the standard we set was that the individual level accuracy be at least 60%. 0.6 AUC, and the population level accuracy, which is essentially the idea on the population level accuracy was that it's possible that even though individual women are giving the incorrect answer, that we sort of have canceling errors. And so just as many women said yes when it was no, as women who said no when it was yes. So in terms of receiving a service. So that would still give population level accuracy. When we look at both those standards, we tried testing 17 indicators. Unfortunately, some of the most interesting ones, we didn't have enough variation in the data to really be able to test, but only these 3 out of the 17 were validated. And that was that a woman delivered in a hospital versus a health center. Well, it's good that that at least was okay. That a woman had a companion present during labor and delivery, and at least one of the thermal newborn care indicators. So that was the newborn was placed skin to skin on the mother's chest. We looked at several other variations on this indicator, and those were not confirmed. So it was disappointing to us. One that we certainly wanted to validate was that a woman received an injection as a kind of a proxy for whether or not she'd actually gotten active management of the 3rd stage of labor. and that was about as good as flipping a coin, unfortunately. I, having never given birth myself, thought that would be really a salient event, but I guess, who am I to say? I guess labor is a much more painful experience than maybe I had expected. So maybe receiving an injection doesn't really seem like a big deal after all that. Okay, so that's one piece of data. You know, what would we do from household level surveys? I think it's problematic is the point. What could we get from facility level assessments? Well, there also is another piece of work done under MCHIP where we looked at, again, actually the study I just showed to you was piggybacked on this 7-country assessment of the quality of care. So looking at all 7 countries, and we had about 3,000 deliveries in the database, we looked at certain key indicators to see essentially what I'm showing you here, a summary of it, which is to try to put to the test the way that we usually do facility level surveys at a national level. And the way they're usually done is not to directly observe care. That's quite expensive and difficult to do, although it is done sometimes now. And the service provision assessment of the DHS now does that sometimes, has done it in Malawi, and possibly will do it other places. But generally, what we measure is service readiness. So in other words, there is a drug, there is a skilled provider, there is sufficient infrastructure, et cetera. So we said, okay, the 100% level across this graph is every woman should have received the intervention. So if we, ideally everybody would have received all these interventions, and across the bottom, I know it's not very big type, I'll tell you what's there. Infection prevention during initial assessment, and we just meant the provider washed their hands. Partograph was used during labor. Oxytocin was used in the 3rd stage of labor. Magnesium sulfate was used in cases of severe preeclampsia or eclampsia, and the cord was cut with a clean instrument as a measure of essential newborn care. And so that should have been 100%. Everybody who was a skilled provider should be doing all these things all the time. Of course, they didn't. And you can see the black lines are how many women actually did receive them. And you can see that there's quite a gap. And even some of the things that are quite easy to deliver were not delivered much of the time, like infection prevention and during the initial assessment, in other words, washing the hands. The more disturbing thing maybe for measurement is those funny colored bars above that. We said, well, okay, sometimes there wasn't actually a skilled attendant there. Believe it or not, when you go to a hospital, sometimes the janitor really does deliver you in some places. And we certainly observe that to be the case in a number of these places. And so the little green bar, you can see it's quite small, it's hard to see it there, was when that happened. So that explained why, okay, maybe the janitor didn't realize that they were supposed to give that to management. Commodity was not present in other places, so that certainly is a problem, and you can see the red bars, and that explains it. But the circled purple bars there at the top of the bar are what we called unexplained. In other words, skilled birth attendant actually delivered the baby, and there was a commodity that was present, and yet the service did not actually occur. And this, in other words, if we did a facility readiness survey, we would not discover any of this. And the problem is that not only is the gap quite large, but it's variable across these different services, and it's not easy to kind of decide why it should be big in some cases and not others, because it certainly isn't by how difficult it is to deliver the service. So that certainly makes measurement difficult as well. I suppose I'm throwing out some problems here. Let me take one last thing here. Now, Steve has already talked about HMIS, and certainly the pros here are that it's readily available, regularly reported, and it should hopefully promote good habits of data use. The cons being that it's incomplete, and in terms of there's incomplete and inaccurate reporting. But in addition to that, even if it was complete and accurate for the places that were delivering the service, then that still doesn't talk about the women who are delivering in private facilities, because as Steve has pointed out, private facilities usually are not feeding into the HMIS, or women who are delivering outside of a facility. I will just kind of leave it at that for HMIS, because Steve has certainly covered that much more completely than I could. Let me just leave you with this last slide here. And I think there's some interesting novel approaches that people are thinking about. I think it's going to take some change in thinking. HMIS certainly is a great place to start, and data quality is going to be a big issue there. But let me throw out another thing that people are working on. Some folks from Hopkins are thinking about this, and some with quite a large group of co-conspirators, so to speak, of trying to think about ways to link facility and population surveys. Maybe we ask a woman on the population survey where she delivered, and we have some sense of what the quality of services are in those different facilities in the area. That's one way, and then possibly we can adjust a score for coverage based on the quality that's known in the different facilities. That might be one way. Throw it out there for thought. And some of the content that we might be trying to measure, again, trying to get in deeply into quality issues is one thing, but in terms of just kind of being able to track sentinel indicators, I'll just throw up these possibilities here. And one that at the very top of the list there, that's on here for content, is one that MCSP, Maternal Child Survival Program, is going to be working on. That's the late stillbirth and very early neonatal death rate, which is an interesting indicator, I think, because it gets both at the quality of intrapartum care as well as the quality of newborn care afterwards, all with a single neatly measured indicator. So we'll see how that works. Thank you.
Thank you very much, Jim. These two presentations that questioned some of the most important indicators that we've been using consistently, skilled birth attendance and antenatal care visits more than 4, and the challenges involved in the different sources of information we use for measurement, basically women's reports and how to contrast that with observations, are both a very, very good segue to the next presentation, or two presentations that you will, one presentation, two speakers. We will hear from Anne Blank and Charlotte Warren in a minute, and they will describe a project that will definitely add to the discussion that Jim and Steve started. So Anne is a vice president and director of the Population Council's Poverty, Gender, and Youth program. Under her leadership, the program has increased investments in rigorous research on programs for adolescent girls, exploring the importance of various project elements in improving girls' lives. She's also leading a renewed focus on girls' education and emerging work on the impact of climate change on vulnerable populations. Her recent research is aimed at improving the quality of measurement in household surveys, estimating patterns of maternal mortality, and examining the circumstances of vulnerable adolescent girls. Before joining the Council in 2011, Anne was the director of the Maternal Health Task Force. She was my predecessor, and she remains the senior advisor to the project. Between 2005 and 2009, Anne was the program officer in the Population and Reproductive Health Program at the MacArthur Foundation. She has extensively published, and she received her PhD in sociology with a concentration in demography from Princeton University. And I think I will introduce Charlotte as well, because I don't think there will be a transition between both speakers. Charlotte is a senior associate for maternal and newborn health and reproductive health systems and research, also at the Population Council. After 12 years in Kenya, she's one of the Population Council's lead social scientists with extensive experience in research, policy, and program development in maternal and neonatal health, reproductive health, family planning, and primary health care. She's a nurse by training with expertise in pediatrics. Charlotte has worked in 10 African countries, building the skills of policymakers and program managers to address critical public health issues. She co-developed the community midwifery approach in Kenya as an additional strategy to increase skilled birth attendance at birth. She has a focus on other areas of research in the sub-Saharan African region, including developing a comprehensive package of postnatal care, assessing the benefits of integrated HIV and reproductive health services, evaluating voucher and accreditation interventions for reproductive health, and the issue of disrespect and abuse of women that takes place during childbirth in healthcare facilities in Kenya. So welcome, colleagues from the POP Council.
This is the nasty message from the lawyers. You don't have to worry about it. Okay. Good afternoon, everyone. Thanks for coming. My colleague, Charlotte Warren, and I are going to share with you the findings of 2 validation studies that we carried out in the last few years with funding and support from the Maternal Health Task Force, and with continuing funding from the Intervention Coverage Measurement Group at Johns Hopkins, which Jim just mentioned, both of which ultimately are funded by the Bill and Melinda Gates Foundation. I am lucky that I don't have to give you the whole context within which this study was done, because you just got it from my the two prior panelists. But I do want to say that one of the things that I was thinking of when I was thinking about this presentation is it's interesting to me that people now are kind of pushing for dropping various indicators, especially the skilled birth attendance indicator, and there's some debate about it and so on. And I think that we should all be thinking about what is the level of evidence that is needed to stop measuring something rather than to start measuring something. I can tell you from personal experience, and Annie Cross, my former DHS colleague, can verify this, that when these questions about maternal health were added to the DHS way back in 1985 or 86, there was no evidence. I mean, these things were based, there was no rigorous validation that went on. There was common sense, there was experience, there was on-the-ground experience, but there was not rigorous validation. And we're now trying to do that in some ways, but I think we shouldn't rush to stop doing things too soon. Okay, so the study objective was, for these 2 particular studies, was to validate women's recall of care received during labor, delivery, and the immediate postpartum period. I think that song was popular in 1986.
Would you mind turning that phone off?
Sorry.
Thank you.
The specific methodology is almost exactly the same as the study that Jim just described that MCHIP did in Mozambique, and that was on purpose because we wanted to have a study that would be comparable to that one. So what we did was we compared facility-based observation by trained observers, which we consider the gold standard, the truth, and women's self-reports that were gathered via face-to-face interviews just prior to their discharge from the facility in which they delivered. Just to give you the basic facts on the numbers and the places, our target sample size was 600 women per country. We did this in, I guess I should have mentioned, Kenya and Mexico. The women were eligible for the study if they were between the ages of 15 and 49 and were admitted for delivery into one of the facilities in which we did the study. Not all of the women who were initially enrolled, ended up progressing to be in the study because some of them were sent home because they didn't go into labor, or for another reason we weren't able to observe them. In the end, we had 660 women in the 2 hospitals in Kenya, which were district and provincial level hospitals, and 600 women in the largest public hospital in Mexico City. This just shows you basically where the the facilities are located, and some basic numbers about the populations, the sample or study populations. Most of the mean age of women in the study was about 24 years in both places. Most women were giving birth to either their first or their second child. And in Kenya, the C-section rate in those two hospitals was about 13% of births. We were not able to collect information on women who gave birth via C-section in Mexico City because after the study started, the surgeon, the director of surgery, decided he wasn't going to let us into the operating room anymore. So we have only data on a few C-sections before we had to stop there. So how did we decide what we were going to measure? Back in 2012, we conducted a very extensive landscaping scan of indicators of maternal health contact quality content that were either in use, had been used, or were proposed for use. We looked at both population-based and facility-based indicators. We ended up with a list of 285 indicators that had either been used or proposed for use. We then took that list to a group of experts during a meeting in September 2012, and we came to agreement on roughly 95 of those indicators that we were going to try to validate in these studies. The ones that overlap, of those 95 plus, the ones that overlap with the data that's currently, or at the time anyway, was collected in the DHS or mixed surveys are shown here. The type of facility, although the study wasn't really designed to measure that because we only had 3 facilities, but we will show you some results on that. Birth weight, the skilled birth attendance indicator, C-section in Kenya, when the decision for C-section was made, and you can see what the list is there. So, when we tried to validate these indicators, we used the exact question wording that is used in the DHS. We also had some input from a group at WHO that has been trying to propose a set of global core indicators on maternal health. And we looked at some of those indicators as well. The first one is the proportion of women receiving oxytocin immediately after the birth. And we didn't actually measure that. What we measured was women who received an injection, the indicator that Jim was talking about earlier, the proportion of women with prolonged labor, and the proportion of newborns who received the elements of essential newborn care, although we didn't ask about delayed cord clamping because I believe it's no longer the standard of care in Kenya. Is that right? I may be wrong about that. There's something about the standard of care. Someone will tell me later. Okay, the analysis that we did, again, exactly replicated the procedure that Jim mentioned earlier to look at individual level validation. We measured area under the receiver operating curve, and that is an indicator that varies between 0 and 1, with 0.5 being basically random. And we decided to use the same benchmark cutoff that they had used in Mozambique, which was an AUC higher than 0.6. For the population level validation, we used the what's called IF inflation factor, which basically measures the prevalence that would be obtained using population-based survey methods. So by what factor would you have to multiply the percentage you got to replicate what would you obtain in a population-based survey? And I'll show you how that looks in a second. Okay, so to move on to the results, what I'd like to talk about first are the indicators that had positive results on both or one of the measures, the tests of validity that I just mentioned. Then I will talk a little bit about indicators that we don't recommend, and then Charlotte will talk in more depth about 4 of the key indicators that we think have some interesting results. So these are the indicators that met both criteria, both the AUC, individual level criteria, and the IF, the population level criteria. As you can see, there's no overlap. So there's no indicator that met both criteria in both countries. The fact that an indicator didn't meet both criteria doesn't necessarily mean that it's not valid. In some cases, what happened was we were unable to validate the indicator because there wasn't enough variation. So we only did the tests for indicators where we had at least 5 counts in each cell. And when you have in a 2-by-2 table where you have the observer measure and what the woman reported, and sometimes because everybody had got something or nobody got it, there was a 0 or a 1 in one cell, and so we couldn't validate it. And that happened in quite a few cases. But of the ones where we could measure both measures of validity, these are the ones that came out. And there is, by the way, no overlap between any of these and any of the ones that were validated in the Mozambique study either. So these are the ones that met the population level criteria. In other words, they had an inflation factor that was between 0.75 and 1.25. And you can see again, there isn't all that much consistency here. These results are quite difficult to summarize because there isn't much consistency. And these are the ones that met the individual level criteria. And there's a little bit more consistency. Okay. These are indicators that had very high levels of don't know responses. And therefore, we believe that they should not be recommended. Whether or not the provider washed their hands with soap and water, whether the baby was wrapped in a towel, whether the provider did a perineal exam immediately after delivery. And again, you can see what the ones are in Mexico that had high levels of don't knows. On the whole, the indicators that were related either to the names of drugs, like oxytocin, diseases like HIV and HPV, which women don't always know the difference between them, and things that happened immediately postpartum, like whether the baby was wrapped in a towel, certain exams that happen right after the delivery tended to have higher levels of don't know responses, which makes perfect sense. And in Kenya, because we looked at cesarean section deliveries, we were able to do an analysis to show, to test what factors were associated with having a C-section. And again, totally not surprisingly, women who had C-section were much, much less likely to know whether their baby was wrapped in a towel after birth or whether the baby was immediately dried. And therefore, one of the things that we would recommend based on these results is that maybe for women who had C-sections, it's not appropriate to even try to report on some of these types of indicators that happen immediately after the birth. And now Charlotte.
Thank you.
Thanks, Anne. So now I'm going to go into a bit more detail on these 4 indicators from both Mexico and Kenya. So we've heard earlier about the type of facility And that is an important indicator, although, as Anne said, we didn't actually go out to measure that because there were only 3 hospitals, and they were public hospitals in this study. But we replicated the methodology of the DHS and MIC surveys, and women were asked to identify where they gave birth by first indicating whether they delivered in a public or a private institution, which is on the wrong one. Up here. So where did you deliver? And then women were then asked to specify the facility type as a hospital, health centre or health post or other location. And if women were unable to determine whether the facility was public or private, they were then asked the name of the facility where they delivered. Cross-tabulation results show that of women who classified the facility as public or private and then specified the level of facility, 85% of women correctly classified the type of the facility as a public or government hospital. But 24% of women were not able to classify the general hospital as a private or public sector facility, but did specify the actual name of the facility. And 83% of these correctly specified the name as the name of the hospital, the General Hospital, the General Hospital of Mexico. And an additional 9% of women who could not identify the type of facility were able to report it was a hospital of some kind. And then a further 4% of these women were able to report the sector or government facility, the facility was a public or government. So the fact that women could identify the facility's government or public sector hospital by being asked to report the facility name in an open-ended question, but were not able to classify the facility using pre-existing categories, suggests that more women are able to accurately report on the facility type than captured in initial questioning. So it's by having the two questions you reach a wider group. So going on to the skilled provider delivery indicator, and this is from Kenya. As you might expect in a facility, we had a high prevalence of skilled attendants during delivery in both countries, but with low specificity. The area under the curve was not met in Kenya. And again, in Mexico, there was not sufficient variation to assess, but showed a similar story with high sensitivity and low specificity. In Mexico, almost all providers were doctors or medical residents, around 97%, and with a few nurses, so we were unable to assess for this skilled birth attendant indicator. But in Kenya, the inflation factor is close to 1 and therefore may well be suitable to generate population-based coverage estimates, but not at the individual level. So we also asked about the main provider delivery, because quite often there's more than one person coming in and out during labour. So at the delivery point, we asked women who was with you who actually delivered your baby, i.e. who caught the baby, rather than the ones coming in and out during labour. And in Kenya, the most common skilled provider is the nurse midwife, with 81% of observed prevalence. And you can see there was a high sensitivity and specificity, whereby both validation criteria were met. However, as I said earlier, in Mexico, because 97% of the deliveries were done by a doctor or medical resident, only the population level criteria is met. So in summary, regarding the skilled birth attendant indicator, we see that a nurse midwife as the main provider is validly reported in areas where this type of provider is common. However, our descriptive results show that women do tend to over-report the presence of a doctor and under-report the presence of medical residents or intern. Probably any male in a white coat with a stethoscope is considered a doctor. In Mexico, the doctor, OBGYN, medical resident was the primary provider, more than 90%. An analysis of finer distinctions among provider types was not possible due to the limited variation in the provider type. In Mexico as well, almost all providers were actually medical residents, and most women reported them to be doctors. But in the Mexican context, there's very little distinction between these roles, so this may not be programmatically meaningful. So taken together with the Kenyan findings suggest that indicators of common primary provider types can be reproduced with accuracy at population level. So moving on to uterotonic for PPH, we developed a composite indicator from the women's self-report, trying to account for all possible routes of a uterotonic. So in the first few minutes after delivery of your baby, did anyone give you an injection in your thigh or buttock, medication through a tube in your arm, or tablets? So these are the results presented here for Kenya, and you can see there was a very high reported and true percentage there. So I mean, that's a good thing. It looks like, you know, a very high percent of women did receive the uterotonic. But because of this robust analysis, it's limited because of the lack of variation in the boxes. This slide shows Mexico data, and this looks at the prophylactic uterotonic. So they received prophylactic uterotonic as a yes or a no, was not able to be analysed robustly, but had a lower sensitivity of 61%. And the timing of the uterotonic within 3 minutes of delivery did meet the inflation factor criteria at individual level, but had a high false positive reporting. So across countries, the evidence is mixed, mixed results. Taken together, women do not have a comprehensive knowledge regarding if and when a uterotonic was received. And in Mexico, nearly 40% of women responded don't know when questioned about receiving the drug oxytocin by name, but we didn't ask that in Kenya. So we compared the women's report of receiving an injection or medication for PPH with the self-report of receiving oxytocin. And results show that a high proportion of women responded to don't know. And of women who reported receiving the medication by IV line, 70% were correct in that they also received oxytocin. So approximately 30% of women who reported no oxytocin, nearly all of these were actually observed to receive it. So there's quite a lot of confusion there on what the women know, the name of the drug and what they received. So moving on to the skin-to-skin indicator. In Kenya, we asked two questions. There was a high inflation factor on the skin-to-skin indicator at 4.9, and on the composite measure for essential newborn care. So we asked the women, did someone place a baby on your chest against your skin immediately after delivery? And there was a yes/no response. And then we said, was your baby wrapped in a towel when they put the baby against your skin? So 85% of the women who said yes to question 1 then said the baby was wrapped in cloth while laying against the chest, not naked skin to skin. So this highlights the importance of indicator wording and shows that multi-step questions may be more useful in enhancing accuracy. Because the 2-item skin-to-skin indicator had an inflation factor of 1.8, which had reduced from 4.9. In Mexico, almost no infants were placed immediately skin-to-skin, and so we weren't able to robustly analyse that indicator. So in summary of the DHS mix and WHO PMNH indicators, 3 met validation criteria. So if the main provider during delivery was a nurse midwife, infant was a low birth weight, and caesarean section was performed. The skilled birth attendants may produce valid estimate at population level, but at individual level, women tend to overestimate qualifications, but at the aggregate level, this gets cancelled out. And then these provider distinctions may be clinically less meaningful. I mean, does it matter whether we have a doctor or a medical resident there? Some of these indicators are also highly dependent on context and wording. especially aspects related to timing, the sequence of events and names of terms, as Anne mentioned, whether it's primary versus other provider, HIV versus HPV, and then the two-step questions may improve reporting. And then the other contacts, as Anne mentioned, contacts that Anne mentioned about reporting the cesarean section status. And this is associated with a high don't know for some of the immediate postpartum events. And women who undergo cesarean section do have different care than a normal delivery. So remaining questions, some of the near universal practices may be validly reported, but full analysis is limited. There's a tendency for false positive reports when few true negative cases occur. And this is unclear if a high sensitivity is due to facility bias. For example, the potential for a uterotonic for PPH, yes, no, but not the timing of the intervention, as to how soon after delivery did that occur. So to explore this further, we're currently conducting a follow-up study whereby all the women, the 600 and something women that we interviewed last year, so they were observed and we interviewed them. We're now tracing all of them. They gave us permission to contact them. So we're now interviewing them again with the same questionnaire to see what changes between 24 hours after birth to more than a year after birth, and also compare what the interview now to what was observed a year ago. And we're also doing some qualitative interviews among a random subsample to try and get more insight into women's understanding of the questions and what factors may influence the actual reporting. And we're just coming to an end of that data collection, so hopefully we'll have more available next time. And this is just my colleagues all working on the team. And thank you very much.
Thank you. Jim and Steve didn't get a round of applause. Well, no intention behind it. So at this point, I think that we would all agree on the importance of measurement, particularly in this juncture, considering that we are transitioning from the MDGs to the Sustainable Development Goals. We used to have we still have one MDG for maternal health, MDG 5, and we face now some challenging global policy situation when we will be subsumed under, I think, 136 indicators that they are considering at this point. So I think that we would all agree that measurement would be very, very critical to keep the focus, keep the light on maternal health. But the challenges are huge in terms of indicators, sources of information, the tools we use, the way we phrase the questions. So we will hear now from our discussant, Tom Pullum, who will hopefully address some of these issues. Tom has a PhD. He's the Director of Research for the Demographic and Health Surveys Program at ICF International. His responsibilities include analysis of DHS data beyond country reports, such as analytical studies, comparative reports, further analysis studies, methodological reports, fellows programs, and workshops. He's involved in a continuing effort regarding adaptation of demographic methods for statistical frameworks and software, and his work with DHS has included 2 methodological reports on data quality. He joined the DHS staff in 2011 following a lengthy career in academia, primarily at the University of Texas at Austin. Tom has a PhD in sociology from the University of Chicago.
First, I want to correct a misunderstanding. I'm not going to be a discussant.
Oh, sorry.
Marge Koblinski was going to be a discussant, and she was injured. She's fine now in a traffic accident. But she thought she'd be able to participate until just a few days ago. And being a discussant would be a much more difficult role.
Free.
So I'm just going to be giving another presentation, which is related to some previous work that I had done, so that it's more a matter of an adaptation. Now, you've heard about many different indicators, but you're all familiar with the primary indicator, maternal mortality. And I'd like to start with some origins of how a target has been developed for maternal mortality for the post-MDG period, and is now in the works. So there was a meeting at WHO in April 2013, and a couple of subsequent meetings to discuss the shape of a maternal mortality indicator. And the two main agencies behind this, as I can infer, are the Department of Reproductive Health and Research at WHO and the Bureau for Global Health at USAID. But there have been many other groups participating, including the Maternal Health Task Force and NGOs. And I have been involved since the beginning because I'm a member of the Technical Advisory Group for Maternal Mortality Estimation that is an interagency UN group. And also DHS is a major source of the data. Why is it useful to have a target? Most of the discussion here has been about alternative indicators leading up to maternal health and survival, but this is more oriented around setting a target, which is a little more concrete. Now, when you set a target, you are required to have a time frame. You have to be specific about what your indicator will be. The value, I think a target has considerable value for mobilizing donors and policymakers. And then you identify strategies to achieve those targets. So strategies are the sorts of things that have been discussed to this point. What would we expect for a target? What are the criteria? I think a target should be ambitious. It should bend the curve. That is, it should not just be a projection of what you expect would happen without any additional resources. It should be achievable. Not too ambitious, otherwise you risk a lot of disappointment. And maternal mortality targets are hierarchical, and there's some consistency that's required at different levels. It should be easy to communicate, and the progress should be measurable. So the time frame for the post-MDG targets begins with 2015, although that's actually not a very good point for setting an initial value. I'll get to that because the value of the indicators for 2015 is not known. Whatever indicator you want to use, we figure it'll probably be around 2020 before you have a pretty good idea of what the values were for 2015. And the end point for the post-MDG or Sustainable Development Goals is currently being discussed is 2030. At one point it was thought that it would be 2035. Now, the primary indicator is the maternal mortality ratio, and you are probably all familiar with this term, but it's actually, the maternal mortality ratio is a rather awkward measure. I think of it as an approximation to the probability that a pregnancy will result in a death. that is due to factors related to the pregnancy. It's an estimate of a probability, but it's calculated as the number of maternal deaths divided by the number of live births. Those two numbers come from completely different sources, and you have no information about pregnancies that did not result in a live birth, but in many cases are a major source of maternal deaths. In discussions of this indicator, there was quite a bit of reference to the attractiveness of the lifetime risk of a maternal death. And that's easier in many ways for people to conceptualize a probability that a woman would die from maternal causes. And that's approximately the maternal mortality ratio multiplied by the total fertility rate, the number of children that a woman would have on the average. But the lifetime risk of a maternal death will decline from either a decline in the probability of the maternal mortality ratio or the TFR. So it's a good measure perhaps of the combined effect of family planning and maternal survival programs, but it is not purely maternal survival. Now, people have referred to the DHS several times. The Demographic and Health Surveys is the main source of estimates of the maternal mortality ratio outside of the countries with good vital registration. And these this information comes from a module, the maternal mortality module, which asks about the sisters of the respondents. So you have the women 15 to 49 who are the main respondents in the DHS survey, and you use them to get an estimate of the level of fertility. And then they are asked about their sisters, to list all of their sisters, and if any of those sisters had died, and if so, was it during pregnancy or at delivery or soon afterwards? There are also other questions about brothers, and men are asked about sisters and brothers because we also estimate adult mortality. But for maternal mortality, the main source is the responses of the women about their sisters. There are some measurement challenges. You've heard a lot about measurement challenges with these other indicators, and they're definitely there for the maternal mortality ratio. One of them is the sampling error, that this is a relatively rare event. And at the bottom of this slide, in an example, I mention the Indonesia survey of 2012, which had 46,000 households. And the questions about the sisters and the number of maternal deaths in the past 7 years turned up 92 maternal deaths. That's approximately 1 maternal death for every 500 households. Now, when you're dealing with something that is that rare, even though Indonesia's level of maternal mortality is not, it's moderate. It's probably around 300 per 100,000 births. You have about 1 maternal death for every 500 households. And you can, as you can imagine, there's a considerable element of chance. So for that 92 that showed up, there'd be quite a bit of a range in possible numbers that could have shown up in a sample that would be consistent with that level of maternal mortality. Another issue in interpreting the maternal mortality ratio is that it refers to an interval of time. So as I said, there were 92 deaths in Indonesia for the previous 7 years. That coming from the siblings, from the sisters. That means that the midpoint of the reference period is about 3.5 years before the survey. So when you see estimates of maternal mortality for 2015, that will actually be a projection. The most recent data point from DHS that will go into the 2015 estimates will be based on an interval of time, and the midpoint of which is 2008 or 2009. So there's a considerable lag between interventions and the estimates of the level. So it's really, you're targeting something when you have a very dim view of where the numbers are. Now, the framework that has been developed has the time frame, 2015 to 2030, and the indicator is the maternal mortality ratio, as I was implying. One of the reasons for staying with the maternal mortality ratio is that it has become familiar because that was the indicator for the MDG goals. The primary goal, the primary target is a global MMR of 70 in 2030. Now notice that this target is specified at a global level. We're not saying that every country should be at 70. That would be completely inappropriate for countries that are already below 70. That's a global MMR, which is based on all of the maternal deaths in the world divided by the number of births and multiplied by 100,000 in 2030. There is a secondary target that no country will have an MMR greater than twice that level. So right now, there's a very wide dispersion in maternal mortality ratios. There are a number of countries, of course, where it's virtually zero. But then there are countries like Chad, I think has the current highest estimate of around 1,200. So that's a huge range, and the goal would be to try to narrow that range by bringing the top countries down so that no country is more than twice the global level. Now, number 5 here is that except for the highest countries, every country will decline at the same rate as the global MMR, even if its MMR is already low. Now, that means that whatever rate of decline would be required globally, and it's about 5.5% as an annual rate of reduction, that would apply to every country, no matter where they are, unless they're extremely high. If they're extremely high, then they have to decline at a steeper rate. I say have to. This is an ambitious goal that the countries that are already at the highest levels would have to decline most steeply. They are going to be the ones perhaps that are most difficult to promote programs in. And the number 6 here is that the highest countries will decline at a steeper rate. And then the last one is within countries, highest priority should be given to high subpopulations, high MMR subpopulations. So this extends to the countries with the lowest MMRs, including the developed countries, including the United States, that the focus should be on those subpopulations that have the highest levels. Now, a little bit more about the primary target, which is point number 3 on the previous slide, to bring the MMR globally down to 70 in 2030. So how was that 70 selected? What we did was to look at previous trajectory, the past trajectory, looking from 2000 to 1990 to 2000, 2010, and focusing mainly on the second part of that. 2000, 2010 was a period of greater decline. Extrapolate that, or you might say look at the annual rate of reduction for that period of time, but bump it up a little bit. And that would have meant that it would be plausible to reach 90 in 2025, 70 in 2030, and 50 in 2035. Now, these are all multiples of 10 selected with that ease of communication in mind. They are rounded numbers, but actually the curve passes very close to those three numbers. And so we were set to go with once the final year was selected with one or another of these numbers. And initially we thought it would be 2035, 50 by 2035, makes a nice, it's a nice thing to say. 70 by 2030, that's a nice sounding target as well. Now the secondary target is that no country will have an MMR greater than twice that. And the motivation there is really equity across countries, that we want to emphasize that all countries participate in bringing the global level down, but extra assistance is going to have to be provided to those countries with the highest MMRs. There are currently 25 countries that have MMRs that are more than twice as high as the global level. And the choice of a factor of 2 is arbitrary, that we set it at twice, but it was felt that improved equity across countries would be desirable. Now, one kind of element of the framework that is probably subject to change is the notion of milestones. These are intermediate targets. Most countries that have a DHS or a mix survey will have one or the other every 5 years. Now, mix in the current round is also doing maternal mortality, so that will be beyond a DHS, will be another source of data. So the progress in terms of these surveys by these high mortality countries can be measured every 5 years. It can be estimated every 5 years. So we have set up some benchmarks or milestones that are 5 years apart that would be intermediate goals. But communicating these has been difficult. So I like the idea of an intermediate target rather than just thinking about what's going to happen by 2030. Then there is some interest in providing regional targets by aggregating the countries in regions. And Latin America and the Caribbean have moved on this. So finally, I don't know what I can do to make these things brighter. I tried coloring them. I am obviously basically at level 101 on PowerPoint, but if you want to find the WHO reports on maternal mortality, you go to childinfo.org, UNICEF site, or maternalmortalitydata.org. More information about DHS, our website is now dhsprogram.com. It was Measure DHS, and that will still work, but dhsprogram.com. There was an article expressing much of what I was just going through in the Lancet Global Health in October 2013. Marge and I were co-authors of that, along with people from USAID and WHO. And another paper on the development of this framework is being prepared. So you could think of this as maybe possibly a framework that could be extended to other indicators if there can be agreement on what those other indicators would be. Maternal mortality ratio is the maternal deaths are the end point in the maternal health process, and some things prior to that end point would be desirable. Okay.
Thank you so much. Your presentation, Tom, really complemented very, very nicely the previous presentations. I would say that the common denominator in everything we heard about this afternoon is that, well, many, many questions about the indicators that we are using. So I would like to open up the next stage of this event by asking the panelists, nobody in particular, if you think we are ready to propose new indicators and what those would be. Because obviously the ones we've been using are not the best ones. Are they the only or the most feasible ones? Are they the ones we should keep tracking in order to be able to assess trends? What would be your recommendations in that respect?
Tough question.
Do you want to start?
Yeah. That's obviously a very tough question, but one that has to be answered. I guess I would say what I think we shouldn't do rather than what we should do. I think what we shouldn't do is jump to conclusions or jump to be too quick to throw out existing indicators, while acknowledging that the existing ones are not very good. I think we should start tracking some new indicators. Some of the ones that look like they might be promising. I think we should do more methodological work on figuring out what makes sense to track. And I think we should develop some better criteria for, I love the framework that Tom was talking about for developing targets for the MMR, and I think the same systematic and thoughtful process should be put into deciding what the indicators should be, the sort of, what are they called? Indicators underneath the goals for maternal health.
Any other comment?
Yeah, thanks. I think I would agree with that. I think that it would be probably premature to drop indicators that cause a lot of consternation. But I think, on the other hand, I think we do need new indicators to give us a better sense of what's going on. It really is the case. I think it's great that this work's gone on with MMR. That's, of course, the kind of lagging indicator, but the one that's most important. It's not sort of thing that's going to help us to make programmatic decisions. ANC and SBA are out there. I think they're problematic, but on the other hand, it's nice that we're applying some level of scrutiny to indicators now as we got started on the work on trying to validate some of the new indicators and some potential different indicators for maternal health within in that study that I was talking about from Mozambique. We realized that a lot of what's already out there in surveys that's been there for a long time has never been validated. So it's good to kind of have that idea of trying to be more rigorous now. So hopefully we can use this as an opportunity now to try to add some new indicators. I think that the very early neonatal death and late stillbirth indicator certainly is an interesting one that hopefully we'll have some more information on in the near future.
Can I just add on one thing, just to say that the Mozambique study that you mentioned and the two that we reported on today, the results of which are not yet published, are, to our knowledge, the only validation studies of maternal health indicators that have been done. Ever. Yeah, we sort of couldn't believe that was true, so we kept looking and looking, and I think it is true. Yeah.
Yeah, we found the same thing. We were surprised as we kept on looking around, and when we did our literature review, we found a few studies, but they really weren't at all the same sort of thing that we were looking for.
Yeah, I mean, these studies are really important, I think. If an indicator isn't measuring what we expect it to be measuring, then it can be pretty fundamentally misleading. So I think, it's long overdue to be validating these indicators. And this applies not only for maternal health, it applies across a lot of areas in global health. I think another, and this is a point I was making before, I think another really important issue is utility of indicators. And it seems that most of the work in this area starts with a discussion of the indicators rather than with the needs of the users. And so that would be my plea. Tom was talking about for targets, like what works well as a target. And I think in that discussion, as Tom was describing it, there was certainly a lot of thinking about what you want that target to do. So what kind of behavior do you want that to produce on the part of policymakers? So how, like what kind of resonance a particular indicator has, or how it's communicated. So I think at that level, these global benchmark indicators serve that same kind of purpose. You're trying to influence decisions by kind of high-level policymakers. You want them to devote more, say, political attention or political will to an issue, or to devote more resources. So that's one user group. But I think there are also user groups, as I was mentioning earlier on, at health facility level, for health facility level quality improvement work, and then also users up and down the system, people in district public health offices or in ministries of health. And they have particular needs. And so I guess I would again call for efforts where we start off by trying to determine for their decision making, what do they really need to know, and what might it be feasible, or how might it be feasible to better equip them with the information they need. And then only after that get to the point of discussion of specific indicators.
Is this on?
It's on, yeah.
Okay. Well, Steve showed a very interesting graph that indicated that there was a negative relationship, if anything, or reverse of what you would have expected, between changes in skilled birth attendance, proportion of births with skilled birth attendance, and the neonatal mortality rate. And that came from it's related to a paper that he and I are co-authors on. Rebecca Winter was the lead author at DHS, looking at changes in neonatal mortality from roughly 2000 to 2010 in the high priority MCH countries that USAID works with. And there are various explanations for that. One of them is that there is probably a selectivity going on where the people who, the women who have skilled birth attendants at the time of the birth are ones who had more problematic pregnancies, that there was some kind of, we would hope, some kind of a referral process going on. And it was not completely successful, but it may well have reduced the level of neonatal mortality to be below what you would have expected without any interventions at all. So that's one of the possibilities, that it's the most problematic births that get the skilled birth attendants in a setting where you have far from universal skilled birth attendants.
Thank you.
So that affects the validity. Some of the validity arguments, I think, have to be looked at closely in terms of possible selectivity.
Jim, did you want to add?
Oh, just real briefly. I mean, I was in a country where a recent DHS had been done. It was discussed at the Ministry of Health, and people in the MCH department were congratulating themselves that their ANC1 rate was 95%. Of course, this is the same place where the IPT rates, the tetanus toxoid rates, the syphilis screening rates, essentially all the content of ANC were well below 50%. And yet, that's not what people cared about. I mean, so people, as Steve say, really react to the things that are measured and that are being tracked. So I think it is really important that we get this right. So I don't think there's going to be any one indicator that's going to be the magic bullet, so to speak. There have got to be maternal mortality, of course. There have to be things like maybe very early neonatal death, et cetera. But the real, where the rubber really hits the road, are on the indicators that are the content of care. I think I would agree with what Steve had said before about that, because those are the most important things. We have to work out a way to make sure that we can get the most valid information about that, so that people are actually reacting to the things that are the most programmatically important.
Thank you. I would like to open the floor now to the audience. Please say your name, the organization you come from, and who you are addressing your question to.
I'm going to take advantage of a mic being right in my face.
Sure.
I have actually a comment and a question, and one of the things that I failed to do in my introduction of you, Anna, besides tearing up your title there, was mention, for those of you in the room who don't know, we often have live webcasts of our events, but we also have archive webcasts. So a number of the panelists, since we had such a robust and stellar panel, have presented in the past, and so we have archives of Anna talking about universal health coverage, of Charlotte talking about disrespect and abuse during childbirth, and regarding maternal morbidity. So I meant to mention that earlier. Now, in terms of the question, because I did have one, many of you probably know that in 2013 we partnered with the Population Foundation of India with support from the Maternal Health Task Force to help them co-host a full-day meeting with maternal health experts in Delhi, and then we had a video conference into an audience here where the rollout of their discussions got shared globally, an audience here as well as an audience based at Harvard. And one of the things that we talked a lot about in Delhi was the JSY scheme. And I wanted to know, this is to all the panelists, your thoughts around the JSY scheme and how, how that factors into our discussion about indicators. So whoever might want to take that first. I know Population Council in particular, I think, did specific studies on it. So if you want to talk about that.
Are you all familiar with what JSY is about? Would you mind explaining?
I bet you could do a better job explaining it than I could. So
Okay, I'm not that familiar with the JSY, but I have worked on looking at vouchers for maternal health care. We did a multi-country study in Kenya, Uganda, Tanzania, Bangladesh, and Cambodia. And basically it was providing incentives for women to access care who might not normally access care. And in India and Bangladesh and Cambodia, women received money to go and deliver in a facility. The challenge is that all these women turn up, but there's no change to what the health system is providing, and the quality of care plummets and maternal mortality can go up. And so the quality of care indicators are critical moving forward on that. The content is absolutely critical.
Thank you. Yes, please go ahead. I cannot see you from here. Yes.
Hi. A number of the panelists know me, some of them don't. I'm Jean Capps, and I've been a consultant for about 15 years, but I worked in the child survival and health program for a long time, and going back all the way before 1990, and a lot of what you brought up is a lot of food for thought, and I know the focus is a lot on measuring progress globally and are we meeting our targets, but there's other uses of the data and there's other things that we're looking at, and so there are questions for each one of them, and I think this is really good when you were looking at the validity of whatever the indicators are, how valid are they. But I had a question about the targets. This is based on our experience from child survival. I was wondering, looking backward, when they've looked at the countries that have made a steep decline, did they tease out the things that they did that resulted in those declines? And then, because from the child survival perspective, the twin engines, when it was started back in the 80s, were EPI and ORS. Those were the two major killers. Once those were teased out, as you went into the more technical areas, as the mortality rates for children went down, it started to reveal more technically challenging, more difficult, more health system reliant factors, and that's how we ended up revealing the newborn was emerging as, because the newborn death was always there. It was just buried under this sea of other deaths. Similarly, with maternal mortality, what I worry about with a logarithmic sort of decline is at some point when you get to the lower levels, I am thinking you will run into the more technically challenging when the diabetic mothers, the ones who have chronic hypertension, those who have other factors going on. But with limited data collection, their deaths will be seen similar to a normal pregnancy that went wrong. So I'm just wondering whether there's been sort of in the discussion sort of a reality check with the clinicians to see whether that kind of rate of decline in that time frame has been discussed. And don't mean to monopolize, but I would like to know the other piece of the puzzle are maternal death audits, and we know all the problems with that, but I'm just wondering whether the other piece of this needs to be maternal death audits when you're trying to validate the causes of death.
Just one quick comment. The global averages that you are referring to don't only hide what may be happening or what we will face soon dealing with the most difficult cases, but also the huge inequalities that currently exist that Tom was referring to. So we will have to deal not only with women who have the most severe complications, but also with them. We should focus more on the most vulnerable women, who are currently the less measured and the less supported. Sorry. Tom.
Well, I'm not aware of anything, any study that has tried to relate the declines observed, especially in those countries, the biggest declines, to specific interventions. Other people may know more about that. One of the limitations of the DHS data is these questions about sisters. You cannot ascribe the characteristics of the respondent to the characteristics to the sisters. So you know, for example, whether the respondent's latest birth was in a facility. You have no idea about the births of the sisters. You cannot assume that the wealth quintile or even the type of place of residence, urban, rural, is the same for the siblings as it is for the respondent. So you can't do any internal analysis, but in addition to another factor, of course, is just not having very many cases to work with. It should be possible to do a macro level analysis looking at interventions, but I'm not aware. Maybe other people are aware of whether that's been done.
In a paper in The Lancet that the Institute of Health Metrics and Evaluation published in 2010, describing for the first time, along with the UN agencies, the big drop in maternal mortality, they attributed it to 4 factors: the declining fertility rates, the increases in skilled birth attendance, and the improvements in 2 social determinants: the higher number of years at school that girls now have, and higher domestic income. Those were the 4 factors that they identified. They are not clinical, maybe except for the skilled birth attendance one, in which we don't believe anymore based on what we heard today. But anyway, those were their assumptions. Any other comment or response?
No, I just think in terms of skilled birth attendance, it's not really clear what components of that, are contributing to the declines in mortality. Just because that data is not collected. It's not easy to collect, and it hasn't been collected, so it would be very difficult to try to make any correlation to say, well, treating severe preeclampsia and eclampsia with magnesium sulfate. That's been the major reason for the decline, or management of postpartum hemorrhage, et cetera. I'm not aware that that study has been done. I mean, other people might know of other things I don't know about, but I don't believe so.
I'll just say that I think it's pretty well established now that declines in fertility, I mean, that's just sort of almost a mechanical relationship. As fertility goes down, maternal mortality is going to go down, but the obvious intervention there is family planning. Right? So that's the thing that I think we're now pretty clear, has been a major factor in the declines in maternal mortality. I will also mention what I think is another one of these puzzles, sort of statistical puzzles when you do this kind of macro level correlation, and that is that you would think that the same countries, that there would be a positive relationship between the decline in neonatal mortality and the decline in maternal mortality across countries, and that is also not really the case. There is not a very strong relationship there, and I think it would be worth trying to figure out what's going on there as well.
Just one quick point too, actually, and other people who are demographers certainly can probably answer this better than I, but my understanding though is we're going to lose the effect to some extent of family planning by only looking at maternal mortality ratio as opposed to rate, so in other words, if we prevent a pregnancy, then that pregnancy doesn't show up either in the numerator or the denominator. If the denominator is live births, and that's the way that we are measuring maternal mortality ratio. On the other hand, if we had number of maternal deaths per 100,000 population, then we would probably better see the effect of family planning, just prevented pregnancies. But it's possible even to get a paradoxical rise in maternal mortality ratio if we prevent low-risk pregnancies through family planning, just an artifact of measurement.
Yeah, family planning will bring down the lifetime risk, but it also has an effect on the maternal mortality ratio because family planning tends to reduce the number of high-risk births, the ones to very young women who are at higher risk, and closely spaced births and maternal depletion and factors like that, which affect the risk. So it's there is a reduced risk of maternal death per birth if fertility is lower.
Thank you. Yes, go ahead.
Hello, my name is Adamma Odefa. I'm a Fulbright scholar under the Humphrey Fellowship. I'm from Nigeria, so I'm going to bring the discussion around to my part of the world. You've mentioned a lot about skilled birth attendants, and I didn't hear anything about traditional birth attendants. We tend to avoid them, so to speak, because we don't want to endorse some unread, uneducated women who are taking birth. But incidentally, in some parts of the world, these are the people who take most of the birth that happen. And I think one of the major problems we have with these women and the services would be hygiene and complications, because when there are complications, of course, they're not able to handle them. And or infections happen because of poor hygiene. So how do we get around this and help these women to take the births that they can take without complications happening or without infections happening? And how do we also convince women to take immunizations, for instance? Because I know in my country, we discovered that a lot of the tetanus vaccines were not moving, they were not pushing out. The women were not coming forward to take vaccinations. And then the women who are in hard-to-reach areas, they are basically the ones who die when there are complications. When there are no complications, they give birth in the villages from this birth attendants. But when there are complications, and that's when there are problems. Are these indicators factoring in these conditions of birth, traditional birth attendants, what to do with them, what to do about hygiene, how do we reach them, how do we train them, how do we help them? medications? How do we convince women to take medications in some parts of the world? How do we let experts, so to speak, if we can find them, help? For instance, in some dynamics, like Muslim northern Nigeria, the community would never allow a man to take birth from a woman. It has to be another woman. And that's one of the reasons why we would have traditional birth attendants. So these are the things that bother me when it comes to maternal health in my part of the world, because the same, like Dr. Rika said, it's almost impossible to find data on these things. It's almost impossible to collect this data because you really don't have anyone there to help you to get them. And that would be some of the concerns that I would want you to address if you could. Thank you.
Thank you. Any comments on or answers to that question or set of questions?
Thank you for bringing us back to reality, which is why we're all here to prevent any women from dying. I think that's why the skilled birth attendant indicator was developed in the first place, correct me if I'm wrong, is to try and measure who is delivering women. And I've worked in Africa for 17 years, and I know the good things that the traditional birth attendants do, and I think the health system let them down because there's the support network for TBAs to transfer women who do have problems. I would like to say that in Northern Nigeria, Population Council has done a lot on reducing maternal deaths due to preeclampsia and eclampsia by introducing magnesium sulfate at hospital level, but also at primary healthcare level, so that midwives can give their loading dose prior to transfer to a hospital. And we reduced the rate of maternal mortality due to eclampsia from 20% to 2% in the areas that we were working. So we are trying to work hard out there, but yes, there are very many challenges.
Maybe just a measurement issue there. In parts of the world where there is a very low proportion of deliveries that happen in a health facility, there still are certain things that can be done to reduce maternal mortality risk. And in northern Nigeria, in Sokoto and Bauchi, there's currently a program going on that involves community-based distribution of misoprostol. And these are in states where the institutional delivery rate's as low as 10%. MCHIP, MCSP has been kind of promoting the use of a combined indicator of uterotonic protection, which is an aggregate of deliveries that are institutional deliveries that are protected using oxytocin, along with deliveries that happen in the community that are protected using misoprostol. So I think it's really important to recognize that in many of the countries that we work in, there's still a lot of deliveries that happen at home. And even if the dogma now is that we don't touch TBAs with a 10-foot pole, still, if we can't write off that whole segment of the population that don't manage to get to health facilities. So we need programmatic responses that are appropriate, and we need indicators and measurement approaches that track performance at that level as well as in the health facility.
Building on that comment, I would like to make my own. The emphasis on skilled birth attendants and the poor reputation of traditional birth attendants basically started in 1997 at a conference that celebrated the 10th anniversary of the Safe Motherhood Initiative. And it came from a reasonable notion that most women who die as a consequence of pregnancy or delivery do it because of unpredictable complications and very severe complications. And the traditional birth attendants, as you said, wouldn't be ready to deal with those complications. So all the focus went on those supposedly skilled birth attendants, and traditional birth attendants were completely dropped from the scenario. So I think that's very short-sighted, and in fact that traditional birth attendants, because they are there, and they are playing an important role, particularly in those settings where women are most vulnerable, should be brought back to the picture, and we should analyze very seriously what could be done to strengthen their abilities or how to make them productive members of the health system, maybe for some limited roles, but for some very important roles as well. Any other question or comment? So I would ask the panelists to say a few final words. If you like, before we close it, I think we still have a little time to go, but I also see that many people are already leaving, and it's been a long session. So, and I see that there are not any burning questions from the audience. So I think this is a good time to wrap up and finish. Tom, we will start with you, since you were the last to speak.
Well, the only thing I want to mention is the connection with the models for maternal mortality that the interagency, UN interagency group works with. And they're very similar to the models that IHME produces. And the purpose of those models is to blend, to combine a number of different sources, different reference periods. And the numbers that come out in the DHS reports as maternal mortality ratios are really just one estimate. The better estimates, and that's also the case for child mortality, come from the UN and IHME. But in the current model, which is evolving for maternal mortality, there are some covariates that drive the model. That actually, the only things what goes into the model is not just the estimates of maternal mortality, but it's some country-level characteristics. And one of those is the general fertility rate, which is a measure of fertility. And it's, as was mentioned, the probability of maternal death is reduced if fertility is low. That's apart from the simple multiplicative factor of how many deaths, how many births a woman has had is going to increase her probability. Another factor is skilled birth attendance. Another one is per capita GNP. Now, skilled birth attendance figures into the model. That is, the estimates of change in developing countries especially are in some degree driven by parallel changes that are going on in skilled birth attendance. So this indicator shows up in that context. There's an empirical relationship between the level of skilled birth attendance and the level of maternal mortality, and that is, in a sense, extrapolated to countries with little data. And there's a lot of discussion about whether skilled birth attendants should be replaced. There are people in that group who argue that it's a terrible indicator and place of delivery would be a better one to use. So that's another ramification where actually these other indicators feed in to the maternal mortality estimation process. And if some community can come up with a better alternative to skilled birth attendants or some narrowing down of the skilled birth attendants come from the DHS data also. And the actual classification of birth attendants is fairly detailed. And a decision is made as to which of these categories are skilled and which ones are unskilled. Perhaps something a little more sophisticated could be developed.
Thank you. Charlotte?
Just building on that, there's a number in Kenya a year ago. the president decreed that all deliveries should be free. And in our work on disrespect and abuse, we saw an increase in the number of women who felt abandoned due to the fact that more women were now delivering in a facility. So whether facility-based indicator or skilled birth attendant indicator, but a lot of our data shows how many women went to a facility and delivered on their own. So that does need to be taken into consideration.
I just want to make a couple of comments. One is to thank all of my fellow measurement nerds who are here and who actually think this stuff is interesting and worth doing and worth showing up on a Monday afternoon to talk about. I think that even though some of the work on measurement and validation and so on yields results that are a bit disappointing and maybe difficult to interpret and difficult to sort of know what to do. I think that the worst result would be if people threw up their hands and said, well, it's too hard, we can't do it, there's no good indicators. I think if that were to happen, then we would risk maternal mortality being even lower on the policy agenda than it already is. Because as my fellow panelists said, what you measure is what people pay attention to. So I would suggest that we keep working at it, that we keep thinking about it, we keep talking about it. The linking studies that Jim, I think, mentioned, or was it Steve, are going on, or will be going on, and those would be studies where a woman would report that she delivered in a particular facility, and then you would collect data from that facility, and then you would be able to link the two things together. In theory, that could happen, and there's some of those studies that will be happening shortly. That's one direction, but I think there are lots of other directions. So I would just say I would encourage those who are working on this to keep doing so. And by the way, for the donors to fund that work.
Yeah.
Great. Well, I don't have a lot to add. I think it is exciting, the idea of a linking study, and I'd really like to see what happens with that. I don't think anybody should be throwing out indicators. Maternal mortality ratio obviously is important, and people are used to skilled birth attendants and ANC, and those are going to continue to be measured. It would be good, though, if we can get some idea what the content of care is that's going on. And again, like Steve and I both said, I think before, when people start pulling in the idea of quality, then it sounds overwhelming to people. They say, well, quality has got so many dimensions, and there's quality from the provider's perspective and quality from the perspective of the client, and then there's, various, there's amenities and there's technical quality. I mean, I think once it does get into that realm, as important as quality is, it kind of gets bogged down if we're talking about what are global tracking indicators and what not only are global tracking indicators, national tracking indicators. So I think we need to try to keep it as simple as possible. But as simple as possible might not be all that simple, unfortunately. It might not be possible to only just add some extra indicators onto a population level survey like DHS or MIX. They might not be able, these indicators of some sort of content of care that are important, like whether or not a woman received a uterotonic, whether or not a baby got proper thermal care, whether or not a woman had a properly managed preeclampsia or eclampsia event. Those sort of things a woman might not be able to accurately report. And so it might take some creative approaches. Luckily, there are creative people out there working on those approaches right now, and one of them is the linking. And so hopefully that might bear some fruit in the near future.
Thank you.
Yeah, I think we'd all agree that, I mean, where a woman delivers matters, and whether or not a woman delivers with a suitably qualified health provider, that matters. But what matters more fundamentally is what actually happens when she delivers. And so I would certainly agree that, measures like institutional delivery rate, and as far as skilled birth attendants as an indicator is concerned, my objections are, first of all, that it's mislabeled, that it would be better to use a term like professionally qualified attendants, Because skilled birth attendance it's misleading. I would say it's dishonest labeling, so that's one issue. And it's used in practice to measure program performance, and that's, I think, the more fundamental problem. So using a mere contact indicator as a proxy for overall program performance, that's something I think we need to stop doing. It's not that we should stop measuring it, but I think we should stop using it. We should stop labeling it in the way we are, and we should stop using it in the way we are.
Thank you. Well, I will not try to summarize the very, very complex concepts and experiences that were discussed today, but I would say that just 3 or 4 points came up during most of the presentations, that it's important to consider multiple sources of information or of data to assess a particular aspect of maternal health, that validation studies are very much needed, that we need innovative ways to collect data, we should, I like very much what Steve said about starting with the need, the perceived need by the policymaker to identify where to invest our measurement efforts instead of starting from the other end, as we usually do, at least that we as technical people working in maternal health, and also the importance of focusing on content of care. I would like to add just one comment about institutional delivery as a possible substitute to skilled birth attendance. Although I obviously question, as you all do, skilled birth attendance, I don't think that institutional delivery would work either. I mean, you mentioned JSY. I think that's a perfect example, and there is also evidence from Kenya that show how these conditional cash transfer or non-conditional cash transfer programs increase the number of women delivering in facilities, but the maternal mortality is not improving because of content issues. So I'm afraid we don't have the answers yet, but I completely agree with the panelists that we still need to work on measurement and make sure that our work contributes to keeping maternal health very high in the global policy agenda. So thank you very much for your wonderful presentations, and thank you all for your interest in these panels. Thank you, Sandeep, again, and the Wilson Center for hosting us and for helping us organize this very important event. I don't know if I'm missing anything.
No. I just to build on that, thank you for coming and participating in the dialogue. Definitely encourage you to continue to have these conversations, whether it's following our website, Facebook, Twitter, or blog. The only last thing I wanted to mention was, it is World AIDS Day, and I would be remiss if I didn't mention that we also had a panel on maternal health and HIV earlier this year. So that's another thing you can tap into in our archive videos if you're interested. So thank you.
If I may add one ad,
Sure.
Thank you for reminding me of World AIDS Day. Today, we are publishing a special issue in JAIDS, the Journal of AIDS, on maternal health and HIV/AIDS, which is the first issue that I'm aware of on this particular aspect. Focus on the mother mostly, not so much on the vertical transmission of HIV/AIDS and the synergies or implications of both maternal health and HIV/AIDS.
Yeah, a lot of the Maternal Health Task Force wonderful work around women living with HIV/AIDS was featured in that panel that I was talking about earlier this year.
Thank you.
Interesting results. I saw I was looking over your presentation before. Kind of a little disappointing that there wasn't any overlap.